we will be talking about concrete steps for clinicians to make machine learning a reality in a clinical setting. And we have a few guests here who have been here before. For example, Tom Callender, who has been talking to you about autoprognosis previously. We have Professor Stonia Palmer here, who was also involved in our sessions about this topic, and Dr. Brent Ershoff, who will also tell you about experiences with machine learning. So we will have some tutorials and case studies that we will present to you today. There are upcoming sessions in March, April, May, and June, which you can already put into your diaries if you'd like to do so. We will also keep you updated via our emails and our websites. And we will start with a short introduction by Mihaela, and then hand over to Dr. Tom Callender, who will give us the first presentation. Thank you very much and enjoy.
So thank you very much again for joining us. It is really so great to see so many of you here today. And this is our 23rd session of Revolutionizing Healthcare. And we started these sessions together with you, the revolutionary clinicians, in fall 2020, so more than 2.5 years ago. And I believe that it is quite a big and impactful endeavor we are pursuing together. We aim to join forces and discuss how machine learning and artificial intelligence tools can be used to enable you to make changes to improve the outcomes for patients and more generally to empower the entire healthcare ecosystem. But I've been wondering recently how it is for you, the clinicians attending these sessions. You come to these sessions and I hope that you enjoy viewing them and learn from them as well. Nevertheless, I also think that many of you feel like an audience. So I've been thinking, and what I would like to propose to you is that starting today, we change this. We move you from the role of engaged audience to joining the stage. And of course, you may think I'm a busy clinician and I have no time to engage with these machine learning tools at the next level. But what we are going to do today is we invited 3 busy clinicians like you with different levels of experience and knowledge of machine learning to tell you how they have made this journey to engage with these machine learning tools and think in very different and diverse ways about the area of public health. Tom, clinical medicine, Sutonia, and Brent with a very different perspective on how to use these different tools to empower really the clinical ecosystems in the operations room. And I believe that there are numerous clinicians like this in the audience. So again, I would like to propose to start thinking innovatively about how you, the clinicians in the audience, can harness these machine learning tools in your clinic, in the clinical practice to improve patient outcomes, use clinical resources more effectively, improve workflow, and many other ideas you may have to engage with these machine learning tools to empower you in your clinical role and potentially in your clinical research role. So I really hope that you are going to do that and then come join us on this virtual stage to tell our community about the way you are thinking and how these machine learning tools can change your work. And I hope you will follow up on my invitation and you'll email me about joining the stage. Andrew, I'm now giving the baton to you.
Thanks very much. Welcome, everybody. It's very good to see so many of you here. Delighted to welcome, as Mihaela said, Dr. Tom Callender, no stranger to this Revolutionizing Healthcare seminars. And Tom is going to give you a combination of tutorial and case study about the practical steps that you can take in order to make machine learning a reality in your clinical practice. So Tom, without further ado, over to you. The only thing I would add is I think it's going to be quite a lively discussion. It will help me a lot in facilitating that if you can start asking your questions as Tom is speaking, and then Sutonia and then Brent. So do please put your questions into the chat as we go. And I think that will make the discussion able to get off to a rapid and relevant start. Tom, over to you.
Great, right. Thank you ever so much, Andrew and Mihaela. Pleasure as always. I hope you can see that. So I am going to try and cover this as a sort of practical tutorial in machine learning for healthcare professionals. And the kind of three main topics I wanted to go through were problems. What are the big things that people can tackle? Where is machine learning ready for use? Canter through some of the practical steps in implementing machine learning for healthcare professionals and in healthcare situations. So I wanted to talk first through problems, give people a flavor of where these tools are ready, and particularly ready for clinicians to implement rather than requiring state-of-the-art technology. And then thinking a little bit more about planning, how you can go about putting this into practice. And then finally, the actual performance of it. So what do you actually need to get going? And thinking about problems, as mentioned, I'm mainly interested here in where machine learning is ripe for use. So the tip of the iceberg rather than the very cutting edge. And this is important in clinical world because things need to be tested quite dramatically before we can put them into practice. And these are the kind of areas where actually these tools really have reached that level of maturity. So if we think about healthcare problems in four main domains, starting at the top with population health, moving down into institution, individual, and disease, we can think a little bit more about the kinds of problems we can tackle. So starting with population health analytics, things that machine learning is really ready for are everything from area level planning and prediction. That can be resources, where you're going to get the most bang for your buck if you're targeting public health interventions, particularly interventions that are relatively costly or only really relevant for specific groups. Understanding the impact of different area level interventions or policy decisions. And then finally, obviously, we've known a lot about disease outbreaks over the last couple of years, but even moving back, at the moment, we can think that we know the vaccine uptake has been very low in different childhood groups. And so by combining this with different types of area level data, we can do quite good prediction of where we might get outbreaks given certain conditions. And this can again be useful if we're going to then target these public health interventions. If we move into population screening and early detection, well, here really is the kind of premise of precision population health, where we take risk assessment. This means that we can then stratify our population into different risk levels, and then from that, we can tailor interventions. But here with machine learning, we can answer loads of questions. So who should receive preventive interventions? Can we enrich our population so that we can screen for rarer conditions that we've never been able to do in the past and make it cost and clinically effective? Who should we screen for what, from what age, how often should we screen, and then crucially, what should we screen them with? Different types of biomarkers, be those blood-based or imaging or anything else. Thinking about institutional problems, again, this comes down to the prediction and forecasting domain, but service requirements is a big thing. So logistic areas of clinical medicine. Who is at high risk of readmission and how can we stop that? Remote monitoring, hospital at home is becoming a much larger thing. How can we work out who is deteriorating? And then thinking about logistics, but also even down into how do you reach net zero? Coming back down to individuals, here I'm thinking about them in a more holistic way. So what treatment should somebody receive at what point? So the kind of, what's the impact of different types of treatment? Are they deteriorating? Is that combination of diseases causing a problem? And then how do we stop secondary problems? So the kind of secondary prevention aspects. So for example, somebody who has chronic kidney disease, how do we best tackle and prevent them going on to have a heart attack? Finally, thinking about diseases, we can use machine learning to reclassify disease severity and subtypes, work out exactly what would be better rather than, for example, using quite crude classification that we still have in some areas. We can use machine learning to help recruitment for trials and in trial management. And then we can use it in the biostatistical methods and bioinformatics ways for working out genetic markers of disease, predictors of aggressive disease. So all in all, there's lots of different use cases, and hopefully some of this will resonate with some of you when you're asking questions that might be, or thinking about the types of questions where we could apply these techniques. But then we come to planning, and most machine learning seems like a great idea until we start, but actually you can quickly hit roadblocks. And that hopefully is something that we can avoid with a few main questions. And so crucially, of course, what is the actual clinical problem you're trying to solve? Seems obvious, but it's not always apparent in some papers. Who will use, let's say this in this case, the risk prediction model, but it depends on if it's forecasting or not, but nevertheless, who's going to use this model? Is it a clinician, a patient, allied healthcare professional? This kind of changes how we implement things. When are they going to use it? Is it going to be in front of a patient? Is it going to all be done remotely? Is it just an analytics team that's doing it and so has abundant amounts of time? This changes how we think about the tools that we're designing and what we can kind of use as constraints. Why are they going to use the model? Again, this is important to how you're going to get buy-in for it. And then where or how they'll use the model is the final bit. Coming on from that, there are several pitfalls that appear time and again in papers in this area. One of which is often in machine learning papers, you see lots and lots of variables bunged in. This is fine if you're in a situation where you can implement something like this because it's a controlled environment and you're implementing on technology that you actually have lots of control over in the future. So for example, say you're doing something on logistics and you know that you will be able to measure all of these different variables into the future. But if you're doing this in a clinical perspective, having 200 parameters might show you what the maximum ability is of your model, but it's not really going to be usable in daily practice because almost nothing can automate that number of variables. And so you'd never be able to do it at the patient's bedside. Unrealistic variables is kind of related to this, but it's all very well and good saying that you have a great variable for air pollution in your model. But how are you going to get buy-in from people on the ground if it's an area level measure that was done 10 years ago and doesn't really account for lots of different aspects? No model explanation. The machine learning tools that are out there, autoprognosis is a good example, often have inbuilt methods for explainability. And if they don't have inbuilt methods, there are lots of different ways of doing explanation. This is kind of crucial. Interpretability is a key component of medicine, and we can now achieve much more of that. In fact, we can use these machine learning methods to go beyond what we've been able to do in terms of interpretability with conventional statistical techniques. Subgroups. The key thing with models is not just to show how well it is at the top level, but really to show how well it's done in all the different important subgroups that you might be dealing with. And finally, validation. It's really, really important that you think when you're building these kind of models, how you're going to validate them and prove that they're actually doing what they're supposed to be doing, ideally on a data set that's completely separate from the one that you have. Quickly mentioning how to get started in this area. Well, the recommendation that I would have is that you start with automated machine learning. And the reason for this is that auto machine learning augments both non-experts and experts. It's not a secondary class tool for those people who are kind of in the slow lane. Modern machine learning techniques are sufficiently advanced and challenging that even expert methodologists require some sort of augmentation in order to be able to use them properly. These tools encode good machine learning practice, and this is crucial. We have guidelines and things like this in clinical medicine to help with ensuring good practice, but these are all post hoc. With automated machine learning, you actually do it at the time you're building the model. Fundamentally, they provide a high quality baseline for comparison against alternative approaches. You can use this at the beginning and then go off and do whatever you want. And finally, they're actually designed for usability. So for clinicians who may not be that good at programming, it's a good start. So what would you need? Well, fundamentally, at the moment, you or a collaborator or a PhD student is going to have to be willing to learn a little bit of Python. That doesn't mean that you're going to have to become an expert, but just enough to be able to apply the tools. and enthusiasm. In reality, those are the only two things, and we're trying to really help with this aspect because there is a growing number of people who are using these tools, particularly from a healthcare professional background, and we all have common problems that we face or have faced, and so we're really hoping to build a community around this where we can kind of help people out with codes, perhaps be there for office hours, try and put together examples in different domains so that people can really overcome some of the more mundane programming aspects and really focusing on using these tools to solve real clinical questions. So if you're interested, please get in touch with me and Mihaela.
Thanks so much, Tom. That's terrific, really clear, and I think showed very clearly that it is doable now and doable without, the bar is not that high just to get going. And but we have now a case study from Professor Brent Ershoff of UCLA, where you're actually going to see somebody who's been using these techniques for a while, and but very much somebody I think you'll recognize as a colleague, and I think what the example that Brent is going to share with us is one that I think will resonate with many of you. So Brent, thanks so much for joining us today, and over to you.
So I am Brent Ershoff. I'm an anesthesiologist at UCLA, and I specialize in anesthesia for liver transplantation. And today I'd like to take about 5 minutes to discuss how I'm using machine learning to predict intraoperative transfusion in patients undergoing liver transplantation. So massive transfusion in liver transplantation is associated with a host of problems, including coagulation abnormalities, metabolic disturbances such as hyperkalemia and metabolic acidosis, transfusion-associated lung injury, as well as increased mortality. Being able to better predict which patients are at a higher risk of massive transfusion could help guide surgical techniques, intraoperative anesthetic management, such as whether to initiate intraoperative hemodialysis, and help with system-wide issues such as blood bank preparation and resource allocation. And recently, over the last year or two, there's been machine learning approaches that have been shown to outperform conventional modeling techniques by better capturing complex interactions between patient covariates. And in the last year or two, there's been a couple articles employing machine learning techniques to address this very issue with respect to transfusion liver transplantation. However, one of the things that have become clear is that these predictive models from one institution can often perform poorly when applied to data at another institution. These patient populations are diverse, surgical techniques vary, surgical expertise, different transfusion approaches. So therefore, being able to develop a model using one's own institutional data could be helpful. However, there are substantial technical challenges in developing and understanding machine learning models, and building these models by non-machine learning experts is difficult. Issues include model selection, hyperparameter tuning, how to handle missing data, pre-processing of features. These are very difficult. The Schaar Lab has recently come out with a machine learning framework called Autoprognosis 2.0, which can develop predictive models, allowing the non-expert to use state-of-the-art machine learning methodologies and solve classification problems, regression problems, time to event problems without requiring significant expertise. In fact, this is a quote from a recent article saying it allows healthcare professionals to take advantage of state-of-the-art AutoML algorithms in their research without the requirement of extensive knowledge on machine learning. So I wanted to give it a go. So the data set that I'm using has 356 adult liver transplant patients who underwent transplantation at UCLA. There are 36 clinical and demographic variables, and the outcome is red blood cell transfusion, which I dichotomized as greater than or equal to 10 units of blood. This is a code chunk from Autoprognosis, and I literally copied all of this from the Autoprognosis website. The only thing that I changed is the name of the data set and a line to dichotomize my output variable. I clicked go, and I watched some Netflix, and here's the result. So it gives me a weighted ensemble of XGBoost, CABBoost, LGBM with the weights in parentheses, and it achieved an area under the curve of 0.79, which is pretty good discriminative performance. It's also quite easy to perform a host of interpretability methods, allowing models to be understood. And you can also perform, or by getting the predicted probabilities, you can perform decision curve analysis and calculate the clinical net benefit across a range of threshold probabilities. And here we're comparing how autoprognosis performed versus baseline strategies of either treating all patients or treating no patients. So this was fairly easy to do, easier than preparing this PowerPoint presentation. So the future directions, I'm going to collect some additional variables. There's several variables that I know are important that were not included in this data set, such as prior abdominal infection, abdominal surgeries, retransplantation. I want to compare how this model compares to just clinicians' prediction, determine whether or not this model would be useful in practice, and then I could easily evaluate other outcome variables, such as the change in intraoperative sodium concentration or hyperkalemia. Thank you very much.
So we're going to jump straight to the questions that are being asked by your colleagues in the audience. And I saw a great question to get us going from Carsten. Carsten, would you, if you're still with us, could you unmute yourself and perhaps ask your question and bring it to life? Because I think it's a really challenging, in a good way, a really great question to get us going. So Carsten, over to you.
Thank you so much, and excellent presentations. Really nice to see these overviews, also the example. So just want to challenge the idea that we need to restrict ourselves to like low numbers of variables, because that's what I see from commercial companies where I discuss our approach to machine learning in my research group. I'm a clinician, but collaborating closely both with Mihaela and also with machine learning or data scientists inside my group. But it seems to me that our clinical world is actually quite complex. And thus we would need to figure out how to actually represent that complexity towards the models. And what we have today in terms of like prognostic indices is usually using and reusing the same few variables. And we tested in one paper what would be the doctor's choice of variables, and we were way worse than a data-driven approach. So very much appreciate your perspectives on how do we bring data standards that can actually help us implement truly complex representation of the medical problems to the algorithms.
Thanks, Carsten. That's great. Mihaela, would you like to start off?
I'd like to start off, and I'm sure that Tom and Brent will add to it. So first, thank you so much, Carsten, for this very important question that allows me to clarify, I think, a few things that may be interesting to more people. So first, I think that there are multiple clinicians, and you are an example of 2-in-1, or maybe many in one, because you are both a clinician that sees patients as well as a clinician researcher. So let's start with the clinician researcher first. From a clinician researcher's point of view, you are completely right. I think that what one would like to achieve with these methods is to look at diverse classes of variables, both variables. So if it is for me to take back a few years, when we started this journey with autoprognosis, the first time we applied it was to UK Biobank for cardiovascular disease, where some very strong risk scores already exist. Both older ones like Framingham score, as well as more recently in the UK, the Q-risk. And there, what we show that one researcher like you can do, and again, I think that this shows for the power of the imagination of the clinician researcher. We ask many questions, but I think many more can be asked by a clinician researcher. One of them was, given the current variables that these two risk scores that exist in the clinical practice, we restrict our data to that, and we train machine learning models. How much better or worse we can do with respect to those risk scores, given the same number of variables? This is what we coined as a term, the value of modeling. Then we said, what happens if, since UK Biobank is vast, what would happen if we have 400 variables that were at the time, right now many more? would they be relevant? And what is interesting in that analysis was that, yes, they were quite, not 400, but quite a lot more were important. But what was interesting is that for different subgroups, they were important. So for instance, for the diabetics, more information was needed and of a different kind. So what I think these tools can do is they can provide a platform for creativity for clinicians to start put all sorts of questions at the push of a button. Should I have more variables? Should I have fewer variables? How does it compare to these clinical scores? How does it compare, since autoprognosis also subsumes, for instance, statistical methods? Is there any advantage to machine learning as opposed to statistics, given this amount of variables? So I think there is an opportunity, number one, to include more variables, as you rightly say, and from a research point of view, but also to look at the number of variables that may be important in subgroups. Now, if you put the clinician's head of seeing patients, most probably you would like to, especially in a country that may be more resource constrained, not like Denmark where you are coming from, but maybe more like the countries I'm coming from, then one would like to look at the minimum amount of information maybe to consider, because you'll not have too much money maybe to invest in doing all these tests. Plus, often in many diseases is about early intervention and early diagnosis. So of course, the more information you want to collect, that will lead to cost and time. And on that note, what autoprognosis does allow to do, people not use that feature, but we actually have a project ongoing just to highlight this ability, but it's part of the autoprognosis package. We are able to add features as one goes. So we are able to add a certain number of features that would bring us to a particular point. And then if the confidence associated with this particular subgroup is not high enough, one could keep at diagnostic, at runtime, when you have the patient in front of you, add more features. So these innovations we didn't highlight too much in the previous sessions, but maybe in a subsequent session we can do some of that. So the fact that things like autoprognosis have confidence estimates, not only interpretability, but also confidence estimates, allow us to try to understand what additional features will lead to a higher, not only prediction performance, but also confidence in prediction, and then diagnosis by additional features being included. So the reason I wanted to kind of hijack this question and highlight that is that I think to some extent this opens the realm of possibilities for clinical researchers, but also for clinical practitioners to decide the amount of information that's relevant for subgroups and for what use. Is it for research use? Is it for clinical practice? And potentially even for what country? Because again, different countries have not only different population with different genetic factors or other risk factors, but also maybe different costs. So they may need to operate at different cost benefits points. And finally, I think that if you think about the type of examples Brent was mentioning, the data may be the limiting factor. You may not have a lot of this data available, and then is of course a trade-off between the cost of acquiring versus not. But I'll let Brent and Tom comment, and I'm curious what you think, Carsten.
Thanks, Mihaela. Perhaps we can turn to Tom then, because Tom, perhaps you can sort of do the counter if you can, which is just the power of fewer variables, if you see what I mean. I mean, certainly one of the things I've heard from you in the past is that there is more power from fewer variables than one might think. And I'm sure with your colleagues thinking about how to make their first steps, would it be right, we wouldn't necessarily want them to take away the impression that you need hundreds of variables in order to show real value from machine learning. So do you just want to talk a little bit from your experience, not that what Mihaela and Carsten are talking about is not correct, but that there is a lot of value that you can generate with small numbers of variables and features.
Nice, yeah. So I don't actually disagree with Carsten. I think lots of features is useful in certain circumstances. I think my caveat to that is that we're nowhere near ready for it. And So that would be my main point with that. But in terms of thinking about parsimony as end goal in itself, from a practical perspective, and Brent kind of touched on this, when you start to look at the net benefit of different models, so how much extra benefit you get from a few extra variables, you start to find that the differences become so small that actually then you can aim for parsimony. And parsimony is important because, take it from a practical perspective, let's say you are a family doctor, and you could be a family doctor in a hypothetically rich country that could spend an hour looking at a patient. But to do a Q-risk score for cardiovascular disease, that's 22 variables you've got to put into a website. To do the equivalent for lung cancer, that's another 12 to 19, depending on which scores you do. These aren't all overlapping variables, and they don't automatically follow in from electronic health records, because no electronic health record has the data in the kind of format that you might need. And trying to get it into that format is nigh on impossible. So if you're going to sit there, you'd spend the first 15 minutes of your consultation just looking at a risk score, or you've got to do this at some other point. And this becomes really prohibitively difficult at a population scale. So from my kind of perspective, parsimony has real benefits when you're trying to do things at very high levels. Having said, and even when you're actually just sat in front of a patient, but, and this is the crucial caveat, when I would totally agree with Carsten that if we can, in different circumstances, then it's great. But it really comes down to how do we get the variables into how do we collect them? How are we sure that they're doing what we want them to be doing, that they're actually measuring what they're supposed to be doing? How do we do that over time? So in certain circumstances, and I think anesthesia and ITU are great examples of that, because a lot of the variables are highly quantitative. And so you might be able to collect them in a uniform fashion over time. My problem with electronic health records is that, I mean, we've got a great project going on at in lung cancer at the University College London hospitals, and it is one of the big centres for this, and it's a world centre for lung cancer research. But we found that the quality of the data coming out of our electronic health records is really poor, because almost everything's done in free text, and at the moment that just makes it impossible to implement.
Thanks, Tom. And Brent, I mean, you have a couple of people have sort of talked about the kind of the hospital level and anesthesiology as areas where perhaps you could have more flexibility in the data you collect. Is that right? So if somebody, one of your colleagues here on the call, feels they have more control, do you have a perspective on what the right number of variables to be collected is? How should I think about that?
No, I mean, I agree with what everyone said. I think, different clinical or different situations are going to benefit from different number of variables. And, with, decision curve analysis, and, you can quantify how much better someone's net benefit will be if a predictive model is somewhat slightly better. You could probably also calculate what the risk is for actually calculating more variables and code that in as well, and how much time and effort that's worth. So, I think there's not a perfect answer. I do think, in the future, if a lot of these variables are, automated in the electronic health record, and risk models can be just, calculated on the fly, it might be less of an issue. You don't actually have to, think about all of the individual variables and calculate it manually. Some sort of prediction will just occur. And if you have enough faith in it, or you can understand the uncertainty in the estimate, you can act on it.
Thanks, Brent. And Mihaela, I think you've got a follow-up on this.
Yeah, actually, I really
follow-up. Could you also just help the community here just to get a handle on? We've sort of heard two things: lots is good, few is good. Could you just sort of summarize also for people how they should think about this issue of how do they think about what variables and how many variables as they embark on their machine learning journey?
Thank you. Actually, this is what exactly I wanted to reiterate, and then I wanted to respond also to Brent, who I think has a very similar vision with mine on how these methods could be used underneath. So first, I want to say that this right now, I would say, is almost like a pseudoscience on determining how many variables we should have. Should we have a few? Should we have a lot? Should we have these variables? Should we have those variables? Should we have these variables for this particular prediction? Shall we have an overlapping set for a different prediction, because one could make multiple predictions for a variety of diseases at the entry point in a particular clinic or hospital. And, or shall I have different numbers for the researcher or for the clinician? And I think that this is, all of that is becoming now possible to investigate rigorously and systematically with tools like autoprognosis. And I think that that is very, very important to realize. You now as clinician researchers and revolutionaries could now think really for your domain and on behalf of your colleagues, that this process now can be done in a very rigorous way. And this is why I said, if you are a clinician researcher, you may want to investigate a large number of new variables. Maybe you discover new biomarkers that may be important for a clinical trial or for a particular study you may want to investigate in subpopulations. You may also want to think about what variables are useful in your cohort as opposed to a related cohort. All of that can be done very systematically in your analysis, because you no longer need to do try and error or just, let's say, think about it, but you can really try all these hypotheses systematically and understand and report on the basis of tools like autoprognosis, the improved performance in terms of accuracy at the population level, subpopulation level, and also the uncertainty associated with the prediction. Because again, this is maybe a little bit more geeky, and please forgive me for that, but at times one wants to put in this works not only how accurate the prediction is, but also how for the subpopulation of interest, how confident we are that indeed we are making the right prediction, especially if we start to talk about actionability afterwards. So this makes me think that maybe in a subsequent session, we may need to go back and kind of highlight some of these use cases, because I think it's a very powerful and unexposed capability of these tools. And I thank Karsten for kind of opening up this point, which we never highlighted, but I think it's one of the merits of this. And just very, very finally to what Brent has said, I think in the future, one could envision these tools being used in clinics and hospitals when you have a patient in front of you, but underneath running in your electronic health record or whatever way you have to capture information. And maybe that could prompt to you, if you'd do this other, if you'd capture these other variables for this class of individuals, we would be so much more sure about this risk, but maybe not more sure for this other risk. So I think, or we are quite sure in 2 years' time, but if you want to predict what will happen to this person in 10, then you may need to collect these other variables. And again, all of that is possible in autoprognosis. It's up for grabs and for the imagination and the scientific minds of you, the clinicians, to ask the pertinent questions. I think the tool allows for it. Now it's about harnessing the tool.
I very much agree, and we actually have a very nice example in a clinical trial where we use an ML algorithm for selection of patients, and we convinced some of the data managers to enter more data, and actually they improved the precision of the prediction. So it's really important to demonstrate that, and obviously to make automatic harvest of the data eventually.
And what is the quality of your in Denmark? What's the quality of data anyway? I mean, Tom was talking about some of the challenges. Do you start with better data records anyway in Denmark?
So it's a lot of work to improve data quality. Mihaela and I, we have been discussing beforehand that like maybe 90% of the time would actually be spent on cleaning data, getting good enough data, and validating that we get the right input. But what we're seeing now is we're benefiting from a legal decision in the 90s that if you run a hospital or clinic in Denmark, you have to use a specific format for whatever data you provide, and you have to make them available centrally for treatment of patients. But we are now benefiting from that in terms of research data. Still lots and lots of work, but we can actually now get to 3,000 different variables for full cohort of more than 50,000 patients. So we're getting there, but a lot of work.
Right. I think it's a very important message, Carsten, that you brought to us, which is that perhaps we didn't give enough emphasis in the case studies and everything of just how much work one has to do in preparing the data. And actually, it's a big focus of the lab on thinking about the data and how to get the data right for models really to be able to show their full potential.
Carsten was one of the first people to give us this homework.
Well, it's obviously working well in your setting, Carsten. So I think it's a good, and it's certainly something I suspect where your colleagues around, who are present here, will certainly need to be thinking about how to get the data in a usable state. But it's also comforting to know that this parsimony, that potentially they don't need 3,000, hundreds, thousands of variables. We have another great question here. It's quite a technical question. So Javier, maybe I can ask you to unmute, but also can you make sure that can you express your question in a way that perhaps somebody who is not as expert as you appear to be would understand it? Do you mind just sort of fleshing it out a bit as you ask the question?
Yeah, thank you very much. And thank you very much for these great presentations. I think it's very important when you're using probably machine learning models for explanatory purposes, especially when you have different types of data. You can imagine you have neuroimaging data, genetic data, and then probably in the future, other types of data, connectomics, proteomics. So how do you handle confounding, or are there ways to handle this confounder when you're going to use these models for explanatory purposes? For example, even because maybe in the future, some people might think that these models could help improving our way of understanding the way diseases progress and the way diseases evolve. So how to handle these elements? This is question.
Shall I jump?
Thanks very much. Please, Mihaela, I was going to say, please, that sounds like one for you.
So thank you so much for this question. So multiple facets there. So first you talk about over time. Definitely, if you are starting to think about these problems over time, machine learning actually is a very good way to think about the confounding in the time domain. But I'm going to stick for now, because these presentations have been so far about static data. I think even in the static data case, and I will call on Tom in a little bit, but even in the static data case, one of the things that at least Tom and I saw when we looked at alternative methods is that many of the statistical and clinical scores that exist do not come again with a very good way to look at the value of the different variables, the value of different variables conditioned on the availability of other variables, and maybe more importantly, the confidence estimates in the form of frequentist estimates. Sorry for being a little bit geeky. That tools like autoprognosis offer. So very often, so I don't think this is so much a statistics versus machine learning necessarily, even though in the time series setting, I think that this issue does play a role and machine learning could be superior, but that I think will be making up for a quite involved technical discussion. But even for the static setting, I feel that it's not so much about statistics versus machine learning, it's about building packages like autoprognosis that allow for looking at, again, the value of some variables given others, like you say, and looking at how much the confidence for subgroups of patients has changed as a result of this information.
Okay, thank you very much.
I don't know, Tom, if you want to add anything, but.
I mean, so again, I think more from a predictive perspective, it's slightly different from a causal perspective, where the confounding issue is a big problem. But from a predictive perspective, these methods are often quite, I mean, I think that they're more intuitive from my personal experience in terms of how you understand how the variables are operating, rather than just using coefficients and various statistical tests. But then coming back to what Mihaela just said, and sort of leading on from before, I do think that there's a lot of value in trying to understand that uncertainty of the prediction, but specifically around wherever the threshold is that you're going to be doing something. Because if you know somebody's going to going to be treated or not going to be treated or screened or whatever. Those people are quite easy. It's the people in the middle that you care most about. And none of our approaches at the moment, I know you can get a confidence interval out of a Cox model, for example, but we don't really use that very well. And actually the key thing comes back to what Mihaela was mentioning. But if you take the kind of Einsteinian type dictum of everything should be as simple as possible, but no simpler, but you should do that at a subgroup level. Who are your big subgroups? Who are the most where you've got the uncertainty? And then just build different models based on those people. So that allows you in some respects to deal with some of the confounding within some of this. And you can do it within one interface. So it doesn't have to be super complex to implement. For the underlying models, it might be that you just need 3 models to cope with that uncertainty, manage your different variables, and manage your subgroups. They can all be quite parsimonious, or they can be quite big models, but that I think is a good approach.
Thanks, Tom.
Thank you very much.
Filippo has a question. I'm so glad you've asked this question, Filippo, because I think there are many of the people on this call who I suspect are asking exactly this question. So let me ask you to unmute if you're still with us and just ask your question, because I think it's such an important question for this group.
Yeah, thank you. Can you hear me?
We can.
Yes, I was just asking, sorry for taking quite a huge leap back, meaning that we find in our clinical experience a huge gap into the willingness of clinical researchers to bridge the gap in terms of knowledge and acquaintance with computer science and technical background in the Python environment. And this causes a lot of fear and some resistance to having even very simple models be applied to the clinical setting or research setting. So having some guidance in terms of resources to use or to begin using would probably just both make everybody learn a little bit, but also maybe give some internal comfort to researchers and clinicians in this environment, therefore making it maybe creating a virtuous cycle for learning more and being more involved and therefore being more and more expert in the field and therefore being more involved.
Thanks, Filippo. Brent, can I turn to you? I mean, perhaps you can share some personal experience on this as well. It seems very daunting when people say, oh, you don't have to know much Python. I mean, that in itself sounds a bit daunting.
Right, that's right.
Think about it.
That's right.
That's a very good question. I am not a computer scientist. I have no coding background. I do have some, math or quantitative background, but nothing. I didn't know anything with Python. And, it takes a little time to get up and running. I'd say probably a few months of, playing around, doing some tutorials. But, with the code block that I showed in my presentation, I mean, it really is pretty simple to run these models. I mean, when I started learning for the first time about machine learning just a few years ago, the idea of having to tune all these hyperparameters and do all these steps was very daunting. And I spent a lot of time learning about it, and I'm happy I learned about it. But in terms of actually applying it to your clinical practice and being good enough to actually generate anything meaningful, I don't think I would ever be at that level without some of these new tools that groups like Schaar Lab has provided.
Yeah, I can imagine.
And Tom,
I'm very envious.
I mean, it's such an important question for this group. What's your advice to Filippo and people who are saying, yeah, I'd love to make that first step, but how do I do that? You talked about a collaborator. I mean, what's your recommendation of that first Python step?
Yeah, thanks. Well, get in touch with us, because actually we've been thinking a lot about this problem, because it is where we all fundamentally came from. Yes, I can program quite a bit, but I've spent years having to do that. But again, like Brent, I am a pure clinician by background. I don't have any specific computer science knowledge, and it took a long time. You don't necessarily need to do that anymore. And I'd actually strongly suggest that you don't try. You can do it over time. So I think Brent really has the right approach. So let's say you can have an Excel spreadsheet which has the data on it, and then you can learn how to put in the various code blocks that Brent showed. And we are, as part of this kind of community effort, going to put together a few tutorials on literally how to set up a Python environment, how to load in a few things. And then, frankly, once you've got your predictions, you can take them out of Python. Go back to whatever it is that you prefer to use. If you have some experience with data, you can do decision curve analysis and work out the AUC in data. If you like R, do it in R. Our purpose is to kind of give you the tool to help with the machine learning aspect, and the automation bit of that is really important, because as Brent said, the tuning hyperparameters and stuff is something that is beyond most of us as clinicians. And frankly, it's getting beyond most machine learning experts, because Brent showed three models: the cat boost, the light GBM, and XGBoost is the three ones that he produced. Each one of those is coded in completely different methods. They have different hyperparameters, and each problem that you apply them to is means that you'll need different hyperparameters. You can think of them like an engine. All of them work in the same internal combustion method, but if you tune the engine to fly a plane as you did to drive a motorcycle, you're going to fall out of the sky. And they're a little bit like that. With these automated tools, you know that somebody who is a methodologist has provided you with the right methods to be able to optimize them behind the scenes, and then you can go from there. But fundamentally, we are trying, and we're doing quite a lot of work on this, to make this as simple as possible, not to mean that it is not done at a high level. The purpose is to actually improve the quality by abstracting away the stuff that you actually don't need to worry too much about. In the same way that, for example, as clinicians, we give medication and we know what dosage to give and everything else, but that doesn't mean on a day-to-day basis we're thinking about how that drug is interacting with somebody's Krebs cycle. And you can think of the same thing for machine learning, and that is a big focus of this group. But it sounds daunting, but we really are trying to make it easier. So part of the group point of these talks.
Thanks so much.
Thank you very much.
It's a great set of answers. We've got a great question here from Owen. We haven't actually got time to do it, but I think what I'm hearing here, and I'll be talking to Mihaela about this, is I think we should do a whole session on getting the data for clinical use in a clinical setting. I think there's a real need for it, and I think there's some great questions being asked here and some great experience to share. So if we may, Owen, we're going to defer your question to a later session, and I'm going to thank Brent and Tom, and of course Mihaela, and then hand over to Mihaela just to close this out. Mihaela.
Yeah, so thank you very much for this wonderful session and for all the engagement. And what I want to finish with is what I started with. I really feel that these tools are now starting to be slightly less scary. You can view them almost as a plug and play. And I feel it's now time to kind of unleash your creativity and your thinking on how to best use them and create use scenarios that may be unique to you, to your particular healthcare ecosystem. And I want again to ask you to kindly reach out if you do have some interesting and new use cases, to come and showcase them and join the stage here, such that we can learn as a community from you and we can discuss very concrete new use. Because I really feel by looking at quite a lot of the more conventional publications that happen in the clinical space, that they often do not have the tools to really ask these questions about what data set for what problem, what data set given what constraints. And I really hope that this type of tools and you, the revolutionary community in this call, can take these questions and formalize questions such that the clinical community can follow your lead. So please let us know if you encounter such scenarios. Thank you very much, and we hope you join us in March.